Thank you, sir. Good morning. I would like to share some of the work done by us and also all around the country regarding the telemedicine screening for diabetic retinopathy. As Dr. Rajiv has already said that we are expecting around 600 million people with diabetes in the world, with around 1 in 2 people not knowing that they have diabetes. So we see what is in India. See, we know that around 17.5% is the prevalence of diabetic retinopathy in urban South Indians. And so we estimate that around 6 million subjects with diabetic retinopathy in India. This is an enormous public health challenge. So, and still in India, much disease is detected too late for any effective treatment. So this is a setting we think what should be done. As many of us have started doing, the first thing is screening of diabetic retinopathy for the early pickup of the disease. And next thing is creating awareness among diabetics, potential diabetics and healthcare providers. So the screening of the diabetes can either be a clinic based or by outreach camps, like what Dr. Natarajan was saying, diabetic retinopathy for the community-based outreach camps, or it could be a telemedicine-based like opportunistic screening. What do we mean by this opportunistic screening is at vision centers or public primary health centers, government primary health centers, we have two strategy like that in the primary eye care setting and screening in a diabetologist or physician's office. All these places can be easily connected to the base hospital for the reading and grading, and the report can be generated. How we approach in a rural setup in a primary eye care is through vision centers. We have set up around 30 vision centers, and through the primary health center, we have mobile screening units actually. So what is a vision center? It caters to around 50,000 population. It's a permanent low-cost eye care facility which is run by trained ophthalmic technicians and connected to the base hospital with a wide bandwidth internet. And there, what is offered is, once the patient comes, the vision and preliminary checkup by the ophthalmic technician, and then they capture with the EMR, the captured digital images, and the EMR is being transmitted by the internet to the base hospital. And there the final consultation, if required, will be given through teleconferencing to the patient, and the glass prescription and medicines will be given. And patients who require a specialty care will be referred to the base hospital. So this is how the vision center process happened. So initially started with 10 vision centers each catering to 50,000 population around the Madurai, and we have around 30 vision centers now catering to a population. This is one of the rural vision center which cater in one of the areas covered. So there is a cost-effective digital camera-based fundus capture which is done. Along with the EMR, it goes to the base hospital via the internet, and there the doctor grades the images, and we have the address software which automatically generates the follow-up advice, and it goes back to the patient end. So, and there's a small innovation here that's happening with a 78D lens and these attachments for a regular digital camera here, which is what's the ophthalmic technician in the vision center is taking the images with. And now we are even trying to replace this with a handheld. Bosch has come out with a handheld fundus camera, which is not expensive. So these vision centers, this is how the EMR and the fundus looks like on the which comes to the base hospital. Quite good picture to grade the diabetic retinopathy. And we found that actually these, compared to our diabetic retinopathy screening camps, vision centers are doing better as far as the patient coming back to the base hospital is concerned. The productivity is better in the vision center based as well. And if you look at this, after 7 years of a particular vision center, in the catering population, 40% of the diabetics and around 30% of the estimated diabetic retinopathy were screened with this one center, and the uptake was good, around 80% uptake as far as the referral to the base hospital was concerned. So these vision centers ensures a continuity of care, unlike a screening camp. and it created access to those people who really need it, and improves the awareness in that particular community. That was one strategy. Another is primary health centers. They have something every week called a diabetic medicine day, where these patients comes to collect their medicines, diabetic medicine. So the opportunity screening is the mobile van with a fundus camera goes there on the diabetic medicine collecting day and captures the fundus images, and it's transmitted by the internet to the base hospital again. So this is also another strategy for where telescreening happens in the primary health center. The secondary level is either in a diabetologist or physician's office, or using the mobile van with satellite connectivity going to various areas to check the diabetic pool of diabetic patients. So wherever the fundus image is captured, with the EMR transmitted to the grading center, and by the doctor it is graded, and then the system with the address software, system generates the follow-up advice and transmitted back to the patient's end. So once the image is captured wherever it is, the turnaround time is around 1 hour for the reaching to the patient's end. So this is how the telemedicine helps, and the images are once graded by the doctor, the system address software, it generates a report with the possible treatments and sent to the patients. And so this is just one short thing. In a physician's office or setting, once the patient comes and does the preliminary blood checkup of a diabetic, how a fundus image in that setting with the address software, how it is being uploaded via the and being sent to our base hospital, where this doctor grades this thing, and the software generates a reports, and it goes back to the counselor in the diabetologist office, and the treatment advice is given there. So this takes around an hour's time. So primary or secondary level screening happens. The 45-degree single images either taken with a handheld fundus camera, or the one which I showed, the digital camera, sent by internet to for the grading, and then the software generates a report and is sent back by internet or satellite connectivity back to the client's end. So we have in various parts of the country now, with the Shankar Netralaya, Dr. Rajiv already showed, Shankar Netralaya diabetic retinopathy project. Then as Dr. Natarajan sir showed, the project they have. In Karnataka, they have Vittala International Institute of Ophthalmology doing such a screening program. We have in Delhi Sai Retina Foundation doing this kind of a screening. So whatever it is, around 20% of the diabetics have diabetic retinopathy, but since we don't know which 20% have this retinopathy, at every opportunity screening should be done and need not be left to the retina specialist. So with this telescreening, we should maximum utilize it to early detect this disease, so that the prevention, needless blindness can be avoided in diabetic retinopathy. Thank you. Thank you for listening.